So, it involves changing our basic assumptions about services and organisations, creating holistic approaches, open approaches, heaven forbid, services that do no harm, that collaborate with individuals rather than tell them what to do. And it was interesting, I was involved with something else where there was, sounds like a joke, there was a psychiatrist, a psychologist, and a GP. They didn't go into a pub, but no. And talking about sort of hierarchy. And I was saying, well, the consumer, where's the consumer in the hierarchy? So the psychologist was feeling that the psychiatrist was not treating them with respect. So it was quite an interesting conversation. Yeah. That's right. So, having the person at the core of the recovery model. So, as I said, I'm a medical practitioner by training, and the Hippocratic Oath says, "First, do no harm."
That's what I say. Is that Hippocratic or
Hippocratic? There are lots of unreconstructed, medicos out there, but there are also some that are, so there is some shift and there is some change. We know that harm is done to people when their trauma is not acknowledged, and when particular vulnerabilities and sensitivities aren't respected and understood, when survivors are labelled, when they're negated as human beings, and when traumatic experience at the very core of their being is disaffirmed. So we're looking at services that do no harm, that do not blame people for their attempts to manage their traumatic stress. Trauma-informed care facilitates recovery, minimises re-victimisation, and promotes self and community wellness and connectedness. So what do we need? We need a cultural and philosophical shift. New generation of mental health services, allied health organisations, which serve people with histories of violence and trauma. We need every part of the organisation to be informed about the impacts of traumatic stress on development. And that basic understanding needs to be at the absolute core of this process. I think I'm repeating myself, really. So obviously if you engage with those core principles, programs will be more supportive, consumers will feel respected, people's stories will be heard, lived experiences will be acknowledged. Now this is to test your eyes. Can anyone see any of that? So look, this talks about, systems which aren't trauma sensitive, and I'm sure everyone's, experienced that. It's sort of the hierarchical model that we're going to treat you. It's a power differential, which of course for survivors is just a wonderful trigger. Having an authoritarian view that we know best, rather than listening to consumers who no one knows better than someone who's lived something. We talked about labelling, pathologising, overuse of medication, restraint, seclusion and restraint, obviously, enforced practices. If someone who's suffered from abnormal use of control and power, what could be worse? And of course, as a survivor, I feel very easily trapped. There can't be any worse trigger than to lock someone up. And obviously, labelling consumers as being manipulative, needy attention seeking. Of course, the diagnosis of borderline personality disorder would fit high on this list, where consumers are seen as if, it's almost as if they're doing it on purpose to defy people. And of course, obviously some of those behaviours are challenging, but again, if they're understood, the basis of someone who has had a disrupted attachment, hasn't a mother who couldn't respond, or whoever the caregiver was, who has been invalidated, not just in childhood, but continues to be invalidated, who has experienced traumatic stress, then you can understand those behaviours. I've got another eye testing one here. Is this worse?
I'm glad you're sending it to us.
Pardon? Yeah. I've probably sent it in a better form, actually. Yeah.
I'm happy just to get it.
Yeah, so obviously one that collaborates with survivors, that the lived experience is the centre of what's going on. Recognise that coercive interventions cause traumatisation, which traumatisation need to be avoided. Understand the high rates of behavioural issues, PTSD. It's hard not to use labels, but understand that PTSD doesn't cut the whole story. Understand that mental health treatments themselves are traumatising. Obviously, being scheduled, having the police come, being thrown into the back of a van, it's got to be a much better way, and certainly it's been found.
Excuse me, often the police are also, what's the word, verbals people, doesn't they just put them in the back of the van?
I'm sorry?
Often the police also verbals.
Yeah. Yeah, that's right. So it's about educating them as well. And it was interesting, I was hearing from some official visitors who go into mental health facilities and talk to the people there, and found that mental health nurses, or some, and I'm generalising, and I'm not here to bash everyone, because obviously there's informed workers out there, but found that a lot of mental health nurses would rather stay in their nurses station because they actually don't know how to talk to people. That's their fear. So it's about breaking down all of those fears and those barriers, and understanding people as human beings. That's the core of this. We're all human beings, and we can all be vulnerable. So avoid all shaming and blaming and humiliation. Focus on what happened to you. And yes, actually ask about people's trauma experience. Assume that there may be some trauma underpinning behaviours. Inquire about it, understand about it. So what do we need to do to get this happening? Well, we obviously need to do a lot more talking, and ASCA's been involved with the MHCC, with ECAV, Education Centre Against Violence, and with a private group of consumers and carers, trying to drive a national agenda around trauma. Early days, but we're starting to have governments ask us about it. So it's filtering through, it's starting to happen. And I think there's a sense that they know they're not going to be able to ignore it for forever. But it's been begun in the States, and we've learnt a lot from there, and obviously it's a work in progress. So community awareness around trauma. People are scared of other people's trauma. Certainly my personal experience, and again I'm sure you've had your own, was when I released my book, and I had a book launch and I had good support there. But some people after that couldn't look me in the eye. I ran into a friend the next day and didn't mention the book launch, had a nice chat, but not able to go there. So there's a lot of denial. People hear stories about abuse, and they say how terrible, and they think, you know, okay, that's out there, that's in that community, that's over. I had one teacher who said, yes, I saw a case of abuse once, and then I thought it was over. So, you know, so a lot more, we need a lot more education. Stigma is massive, taboo, and that's often based on fear, lack of understanding. So, yeah, a lot of education in all levels. So, successful model, and I mean these are the basic, you talk about recovery orientated practice. It's the same principles, and it's about treating people as human beings, you know, being respectful, collaborating with people, listening to them, hearing them, being empathic, giving people hope. As I said, there's been recent research which shows that just as damaging experiences in abuse can cause impacts on the brain, changes to the brain that are negative for functioning, so new positive and different experiences can cause changes that are very conducive to health and well-being. I mean, that's, you know, really important information. And it also shows that when parents deal with their own trauma, that also helps the attachment of their children and actually helps to stop that transfer of trauma into the next generation. I'm not saying that, you know, everyone who's been abused goes on to abuse their children, but my children certainly were left with repercussions of my process and my abuse. You know, I was very cut off. I was unable to be there for them emotionally. And over time, you know, everyone's done a lot of work, and you know, that's starting to change. They still have their stuff. Two of them have become psychologists. No idea why. Yeah. I suppose the question is, why didn't the other two? So obviously we need integrated, coordinated care, considering the person as a whole. I think we've said most of this, haven't we?
Yep.
Yeah. Yeah. Collaboration between workers and those seeking help. Yep. In the States, it actually shows that this works. This is pretty good. So there are multiple studies that shows that a trauma-informed approach causes decrease in trauma symptoms, decrease in substance abuse, decrease in some mental health presentations, acute hospitalisation, crisis interventions, improvements in the way people feel, in the way people can connect with one another, with the way people function. And this approach doesn't cost any more than current systems, so one has to ask, why wouldn't you do it and adopt it? Oh, that's about us.
Okay.
Just talk a little bit about ASCA, because we have to have the opportunity to give a plug. You know, as I say, we're a small organisation. The website has some, you know, really helpful information on it. I'm going to talk about this blue knot. It's not because I love blue string. We have a national day called Forget Me Not Day coming up this Saturday, as it happens, and our symbol is the tangled knot, symbolic of the tangled knot of child abuse. And we have a lot of activities happening around the country, so if you go onto the website and see what's happening, I've left some flyers out there. We have a launch event at Hyde Park Barracks.